I want to thank the ACC for the invitation to speak about the latest data on influenza and cardiovascular outcomes. My name is Jay Udell. I'm an associate professor of medicine at Women's College Hospital at the Peter Munk Cardiac Center at Toronto General Hospital and the University of Toronto. These are my disclosures. With regards to influenza vaccines for cardiovascular risk reduction, many of you know, influenza is a contagious respiratory illness with a range of disease severity. Has a lot of similarities to what we're experiencing with COVID-19, although we see during influenza epidemics that more people die from cardiovascular causes. And so it was natural to observe that many studies suggest, therefore, a protective effect from influenza vaccination on cardiovascular events. However, only 3 small single-center randomized trials have been studying this question up until recently. And those trials did support the observational findings. And as a result, influenza vaccination carries a Class 1 level of evidence B recommendation in both the American Heart Association and American College of Cardiology guidelines and the ESC secondary prevention guidelines. However, with that limited data set, uptake is low and the vaccination timing is undecided, and the responsibility of who to provide that vaccine up until now continues to be deemed to be the domain of the primary care provider. Along came a recently well-powered, well-sized randomized trial called the IAMI trial, which studied influenza vaccine for cardiovascular risk reduction in patients with acute myocardial infarction and, to a smaller degree, stable coronary disease. And so the IAMI trial studied patients at the time of presentation with an ST elevation or non-ST elevation myocardial infarction that were referred to coronary angiography. And the intended sample size was 4,400 patients. And in a one-to-one fashion, they were randomized to influenza vaccine or to placebo. They've been followed for at least 1 year, and the plan is for exploratory analyses up to 5 years, with the primary endpoint of a composite of time to all-cause death, recurrent MI, stent thrombosis, and various secondary endpoints. The primary results of the IAMI trial were recently presented at the American Heart Association meeting. And this is the Kaplan-Meier curves for the all-cause mortality MI stent thrombosis outcome. Unfortunately, because of the COVID pandemic and other barriers, they were only able to finally enroll 2,500 patients. You can see the breakdown on the left-hand side, about 50-50 breakdown between ST elevation and non-ST elevation MI, with just a handful of stable coronary disease patients as they just expanded enrollment to that population. Nevertheless, they saw here in the red curve for placebo versus the vaccine curve in blue, a risk reduction of 28% or a hazard ratio of 0.72 for those patients who were assigned to influenza vaccine early post-MI out to 1 year. You can see those curves diverge fairly early on, and they continue to diverge throughout that 1 year process. When you look deeper at secondary endpoints, which was interesting because it really does question the mechanism of action, you can see on the left-hand side that effect size was consistent for those patients for the outcome of all-cause or cardiovascular mortality, with a whopping 41% risk reduction, hazard ratios of 0.59 for each of these 2 outcomes. Again, for myocardial infarction, there was a trend towards a reduction, but again, it was not statistically significant. With regards to the subgroups of interest here, based on sex, age, diabetes status, smoking status, prior myocardial infarction, the inclusion MI type, the season of enrollment, or the hemisphere in which the patients were enrolled, you can see by the hazard ratios here and the forest plots that all of the outcomes were consistent amongst the various subgroups with no significant interaction between them. When Professor Frober and his team then combined the results of IAMI in a meta-analysis with prior smaller randomized trials, you can see a consistent treatment effect with influenza vaccine compared to placebo or control, with a, again, risk reduction of 49% or a hazard ratio of 0.51 that's strongly significant. My colleagues and I were fortunate enough to be funded by the NIH to study a comparative effectiveness question in the INVESTED trial. In the INVESTED trial, we looked at patients with a recent myocardial infarction or a heart failure hospitalization and one additional clinical risk factor. And those patients were randomized in a double-blind fashion to one of two different vaccine strategies: a high-dose trivalent inactivated flu shot. Those are fourfold more concentrated than the standard dose vaccine, or a standard dose vaccine that had broader protection with a quadrivalent influenza vaccine. All other standard of care happened in the background, optimization as per usual guideline-directed therapy. We followed them up to 4 times a year for 3 flu seasons, and patients were reassigned and would receive their annual vaccine according to their initial randomization strategy. Primary endpoint in the INVESTED trial was all-cause mortality or hospitalization for a cardiovascular or pulmonary cause within each flu season, and we also studied various secondary endpoints. This data was presented at the AHA in 2020, and the primary endpoint for all-cause mortality or cardiopulmonary hospitalization showed no significant difference between the 2 different strategies of flu vaccine. Again, you can see on the left-hand side, we randomized 5,260 patients, 2/3 of which had heart failure, 1/3 of which had myocardial infarction, and 40% had an LV function less than 40%. So again, out to 1 year, no difference between one or the other flu vaccine strategies. Taking a step back and putting this in perspective with other post-MI evidence-based therapies for the outcome of all-cause or cardiovascular mortality, you can see here across really a spectrum of 40 years of research from the initiation of aspirin and thrombolysis to primary PCI, beta blockers, ACE inhibitors, P2Y12 inhibitors, intensive statins versus standard statins, and now flu vaccines versus placebo. You can see a fairly consistent risk reduction across many of these therapies. If anything, a very robust finding with the flu vaccine compared to placebo. Looking at it in a different way, I like this slide. We put together this slide to really look at the cumulative evidence if you were to apply all of the evidence-based acute MI therapies, including influenza vaccine, over the course of the last 40 years. If you look back in time to the ISIS-2 analysis, 1-year cardiovascular mortality rates from acute ST elevation MIs was 13% at that time. And we've subsequently seen huge amounts of risk reduction over the course of the last 40 years, culminating now with potentially a flu vaccine prior to discharge, resulting in a 90% relative risk reduction compared to that earlier era, or an absolute risk reduction approaching 12%, which would result in a number needed to treat of these guideline-directed therapies of 9 patients in order to prevent 1 additional cardiovascular death. There are still ongoing trials to further address these questions with influenza vaccine for CV risk reduction. Some of them are having challenges at the moment due to the COVID pandemic, but we hope to see the results of these in the coming years. In the RCT-IVVE trial, patients from middle to low-income countries are being randomized to flu vaccine versus placebo, 5,000 heart failure centers. Of course, you could receive open-label flu vaccine if that was the standard of care, and so this would be on top of that. And the primary outcome is a composite of cardiovascular death, non-fatal MI, non-fatal stroke, or hospitalization for heart failure over 3 years. Another intriguing study, and quite large compared to any of the other prior trials, is a pragmatic trial being conducted in Finland, which is looking at almost all comers, adults 65 years of age and older. 120,000 participants are planned to be enrolled and randomly vaccinated with either a high-dose quadrivalent flu vaccine or the standard dose quadrivalent flu vaccine, really then testing the hypothesis of the high dose being more efficacious than the standard dose, for a composite of cardiovascular or respiratory hospitalization, using the registries in Finland to follow patients up for hospitalizations as the primary discharge diagnosis. Follow-up will be within each flu season for those 6 months out till May 31st, with various flu seasons, various years of follow-up happening thereafter. So again, very exciting work that should increase the totality of data in this field. So we just walked through that there is a multi-center now randomized trial demonstrating reduction in cardiovascular outcomes with an influenza vaccine early post-MI, confirming the benefits in the earlier trials. A large randomized comparative effectiveness trial in North America demonstrated no difference in cardio or respiratory hospitalizations or mortality between a high-dose trivalent or a standard dose quadrivalent flu shot among patients with a recent MI or heart failure hospitalization. Our cardiovascular guidelines recommend influenza vaccine for respiratory and cardiovascular risk reduction, They'll likely be updated with this now latest data. And so further efforts and research on implementation are needed. I think this shows that the evidence now is strong, just as strong as those other evidence-based therapies, that flu vaccines should be in the domain of our cardiology clinics and us, the cardiologists, as well. It's very provocative, except I think that more research and more efforts are needed to improve implementation, which is again why I'm so grateful for this invitation today to discuss this latest research and hopefully influence those in routine care. In the coming months and years, we'll be able to study this further, and I appreciate your attention and look forward to further discussions today.